Super excited that Robin Gelburd has come from New York City to be with us to talk about what her organization's doing. Fair Health has about 54, 58 billion paid claims. Paid claims, not billed claims, not fee schedules, but de-identified or identified in some cases, paid claims. And so they can get down at a county level, very granular level, a demographic level, and tell us what the data says about what healthcare costs and utilization looks like, what it means for the market and policymakers here in Arizona. So we're super excited to welcome Robin to the stage. Let's give her a warm round of applause. Robin Gelburd.
Thank you, DJ, for that great introduction. It's my fourth state of reform, and it's such a pleasure to be here because he always creates this thoughtful watering hole to discuss the most pressing issues in the healthcare system today. And even though I'm from New York, I brought $500 million of Arizona claims with me. So hopefully I'll have home court advantage as I start speaking. So for those of you who may not know of Fair Health, we're a rather unusual organization. I'm not really sure of any other like it in that we were created out of an investigation brought by the Office of the New York State Attorney General a decade ago when there were concerns about perceived conflicts of interest in data being used to adjudicate claims, mostly out-of-network claims. And everyone agreed that a new, independent, not-for-profit should be created that could bring integrity and transparency to health insurance information. Even though it was a New York investigation, it in effect became a national remedy overnight, and we serve the entire country. And really our mission was threefold. One was to create a data repository informed by the best thinking of statisticians and economists in gathering claims, auditing and validating and aggregating them in a way to make them meaningful to all stakeholders. Two, as a 501c3 independent not-for-profit, we were tasked with helping policymakers, academic researchers, legislators really think through the difficult questions plaguing the healthcare system today. And lastly, and not to forget the consumer, we were required to launch a free consumer platform that could really give patients and their families unparalleled visibility into healthcare costs and educational information of health insurance principles to really elevate health insurance literacy. We really sit right in the middle of the healthcare schoolyard, if you will, and speak to all the different stakeholders, which really help inform and improve the work we do and the data we provide to really advance sound decision-making across the board. So what do we have and why do people come to Fair Health as an oasis in the healthcare system? We have the largest private healthcare collection in the country, over 28 billion records, which continue to get refreshed monthly. That data come in from private, fully insured and self-insured plans and collectively represent the claims experience of approximately 150 million covered lives. When that data arrives, it gets audited and validated and then gets assigned to 493 different geographic regions because we really believe it's important to capture the medical heartbeat of a market to really advance decision-making. So of those 493, there are 6 geozips in Arizona. Our geozips tend to track with the first 3 digits of a zip code. And as a point of comparison, Medicare has a single geographic region. So you could see we are a much more granular tapestry of healthcare claims. But speaking of Medicare, because of our independence and the breadth of our commercial data, CMS has designated us a national qualified entity, which means we've now been entrusted with the entire collection of Medicare Parts A, B, and D data, and that allows us to do really informative comparisons of the public and private sectors and to make certain public reports available to all stakeholders. Even though we are not a governmental entity, we are almost quasi-governmental. And given, again, the collection of data that we have, and because we're unbiased, many states have stepped forward to ask Fair Health to support their healthcare-related programs in various ways. For example, our data inform workers' comp fee schedules in many states, auto liability fee schedules. We're written directly into the California Healthcare Code. The Arizona Department of Economic Security licensed our dental data for a dental program for developmentally disabled adults and children in Arizona. We've also been figuring prominently in the debates, both at the state and federal level, on surprise balance bills, which you may be reading about. It's really a pressing purple issue right now that everyone recognizes consumers should be protected from these surprise out-of-network bills and bills for emergency services. Then the difficult part comes in terms of trying to design what should be the fair level of reimbursement to providers who offer that care. Our data have been turned to really demonstrate what the implications are of going in different directions, and I'll show you an example of that in a moment. On the federal level, we are relied heavily upon by a number of agencies. The Bureau of Labor Statistics uses our data to inform their medical CPI indices. The Government Accountability Office just recently issued a detailed white paper on air ambulance using our data as a primary source. USDA has really run with our data on food allergies, and the CDC recently issued a press release a couple of weeks ago, to our surprise, saying they are going to sole source their data needs to Fair Health because we're such a rich epidemiological heat map of the country. So our goal really is to take what can be really an opaque ocean of claims that are really indecipherable and bring visibility and clarity so that it becomes actionable data for people to really advance the work that they're doing. We are always delighted to come into a forum like the State of Reform. As DJ said, this is a local conference, and so that's why we brought our $500 million of Arizona claims with us and really want to take you into that Arizona ocean with us. I should say where I'd like to start is something that we're seeing. Because of our data collection, we sometimes become like the canary in the coal mine, seeing certain trends in the healthcare system that are really crucial. One of those trends, and you're probably witnessing it yourself, is the transformation in where patients are accessing care and the availability of a number of alternative venues for care. So we're seeing increasing numbers of claims for venues like retail clinics and telehealth and urgent care centers and ambulatory surgery centers. And that becomes really important because your choice of venue really can determine, one, what the out-of-pocket costs are for the patient. It really also can implicate care coordination and care management issues, provider network design, benefit design. It really has a lot of reverberating issues that flow from that. So let's go to Arizona and look at retail clinics first. And what we did here was we took all of our claims from 2012 to 2017, those claims that reference care that was rendered in Arizona with a place of service field being a retail clinic, taking that universe of claims and showing what the trend lines are. You could see there's over a 21,000% increase in Arizona compared to the 674% increase in the nation as a whole. And there are likely a number of reasons for that, and you probably are aware of many of them. One being that Arizona is somewhat challenged in terms of healthcare access and in terms of PCP assignments. So what you're seeing is the fact that retail clinics are really joining the front lines of the primary care delivery system. You also, over the past 5 years, have seen almost a 40% increase in the number of retail office locations. So again, this is really feeding into that really sizable growth in this particular venue. And so what we did was, once we assigned those claims that had been performed in a retail clinic, let's look at the top diagnoses in Arizona and compare them with some of the diagnoses, the top ones in the nation as a whole. And you will see a lot of similarity, but what should strike you is in the number 4 position in Arizona is chronic respiratory issues. And that really, again, feeds into what we just said as to the role retail clinics are playing in general primary care. People with a chronic condition are going to retail clinics for the management of that condition, which is somewhat unusual when we look at retail clinic data around the country. The other thing that's unusual in Arizona is looking at the age cohorts who are going to the retail clinics. What's really prominent is the fact that the over 60 population is really dominating utilization at the retail clinics. Again, suggesting that population that may have high medical care needs, they are using that retail clinic in a sense as their primary care outpost. Again, unusual when you compare it to the national trends. Because acute respiratory issues was the number 1 slot for Arizona, And because chronic respiratory issues appeared in Arizona, which is somewhat unusual for retail clinics, we thought let's dive down a little bit more deeply just to look at the age distributions for those two particular diagnoses. And again, what's not surprising on the acute side is that it's trends to be younger and those that are probably having one-off infections that are coming in for immediate relief as a convenience matter. Whereas when you look at the chronic respiratory issues, again, you're seeing that same over 60 population really dominating that diagnosis. Let's turn to urgent care now for a moment. So as you could see, Arizona did have an increase. Here we're looking at 2009 to 2017, and we're seeing an over 150% increase in Arizona, which is somewhat lower than the nation. But one thing to keep in mind, as I mentioned, this trending line is showing all claims within a closed system of urgent care utilization. So we arrayed all of the urgent care claims and then trended them over the years. If you looked at urgent care utilization in Arizona against all medical claims, what percentage do they comprise? It would show that Arizona still tracks higher than the nation as a whole. Now, what's really interesting in looking at urgent care diagnoses, a couple of things to keep in mind. Look how much they resemble what's in a retail clinic. What we're seeing with these different venues emerging is a blurring of the lines between these various venues of care. The same diagnoses are presenting, and you'll see something similar as we move even to the emergency room utilization. But again, what should really catch your attention here is in the number 2 position are the chronic respiratory issues. Now, just by its name, urgent care, that was a venue that was intended to really take some of the utilization in emergency rooms that, issues that were not truly emergent, but urgent, that needed a venue and to really have a step-down type of facility. It wasn't necessarily intended as a primary care, ongoing care management type of service. So it's really fascinating in Arizona that you have that being in the number 2 slot. As you see nationally, that does not appear as one. In terms of the age distribution, very similar to the nation, so nothing unusual with respect to Arizona in that regard. With respect to ambulatory surgery centers, Arizona is playing a very large role in that you could see you're number 10 in the country in terms of density and availability of ambulatory surgery centers with 181. So you are clearly on the map in terms of that being an outpost. And because you were in early with ASCs, as you can see, the trend lines are not dramatic. In fact, it's showing a slight decrease just in the last couple of years, rather insignificant, whereas the nation is catching up to Arizona. In terms of the age distribution for ASCs, exactly what you would expect, because at ASCs, think about who goes there mostly, and it's in that 51 to 60 age group where people are going for colonoscopies, endoscopies, arthroscopies. So again, very much in line with the country. In terms of emergency room utilization, here again, Arizona is slightly lower than the nation when you look at the trend lines for just ER claims from 2009 to 2017. However, again, if you step back and broaden the canvas and it was against all medical claim lines, ER utilization would track above the country until 2017, where you are generally in lockstep. But there are some differences that we'll see now. So one, before we compare ER diagnoses in Arizona to ER diagnoses in the country, I thought would be also interesting to really demonstrate that blurring of the lines. Look at the top 5 urgent care diagnoses in the country as a whole. As you can see, they basically mirror what's happening in the emergency room here in Arizona. And now Arizona having a number of freestanding ERs, that blurring is probably even more acute in the sense that there may be even just confusion among patients as to when to go to one versus another. But if you look at now top ER diagnoses in Arizona compared to the top diagnoses around the country, again, what's notable here and probably reflects your unique sort of topography in having freestanding ERs, most states would have cardiac events as the number 1 cause for people to go to an emergency room. Where that is not true is in Texas, which also has a number of freestanding ERs. And because cardiac events generally lead to inpatient admissions, it's not surprising that with freestanding ERs sort of in the landscape, that would dilute the number of cardiac events. So it's not even in the top 5 in Arizona, which is really fascinating. In terms of emergency room utilization by age, you're pretty much mirroring what we're seeing around the country. So nothing really notable there. And now we've done a lot of work in behavioral health, and I know there are a lot of folks here who are really thought leaders in this space and wanted to share some of what we've learned. We do have a free white paper on our website where we took advantage of the fact that we're just coming out of the decade since the Mental Health Parity Act, which also dovetailed with the Affordable Care Act as well. So we thought it was really worth taking a fresh look at what has happened over the last decade in terms of utilization in both mental health and in terms of substance abuse. So here what we did again was looking at the percentage change over that period in claims associated with behavioral health diagnoses. And while we did the entire country, we just picked a few states to give you a point of comparison. As you can see, Arizona is below Louisiana at 187%, but above Texas, Oklahoma, and the nation as a whole. And that may be actually a positive sign in the sense with reimbursement design and benefit design, and with more people having insurance coverage, more people are taking advantage and accessing behavioral health services, which is not necessarily a bad thing. But what's interesting with respect to behavioral health diagnoses, again, where Arizona is somewhat different, look at the top diagnoses in the nation as a whole. It's mental health disorders associated with substance abuse. That is true in many states around the country. That ranks number 4 in Arizona, with major depressive disorder being your number 1. So again, a slight departure from what's happening around the country. The other thing that really is notable in Arizona is look at the age cohorts of those accessing behavioral health services. Again, the over 60 population dominates the age groups, whereas look at it in comparison to the national age distribution. It really invites further study, and that's one of the things when Fair Health looks at some of these statistics. Those that are more anomalous really then invite further scrutiny. We're always happy to support researchers who look more deeply, and then sometimes we go more deeply in a subsequent white paper or study. But the over 60 population, both in terms of retail clinic utilization, behavioral health, there are a number of issues I think that are fascinating in Arizona. Now just moving to telehealth for a moment, because Arizona, this is really new to you all in terms of your April law, which is exciting. It sounds like there's been some expansion of what's being defined as telemedicine. As you know, there are 2 different types of telemedicine or telehealth. We can use them here interchangeably. But synchronous, meaning the care is rendered in real time. Asynchronous, meaning that there may be delay, there may be remote monitoring or store and forward kinds of exchanges. There are people with AFib, for example, who wear heart monitors and are having a feed of their heart beats really transmitted to a cardiologist, or you may be taking pictures of some dermatology condition and then transmitting it to your dermatologist, but not in real time. And it sounds like based on your law, that will now be recognized as telemedicine. My guess is if we were to come back in a couple of years, some of these trend lines would be different as it further expands. But Arizona is already on the map in terms of telehealth, even though here it's showing less of an increase nationally at 96% compared to over 650% for the nation. Again, stepping back, if you looked at it against all medical claims, Arizona would still track above the country, which again means that the trend lines haven't been as dramatic in these last several years because you started earlier, and my guess is you will even pick up more of a steeper trend line with the passage of this new law. Here are the top telehealth diagnoses. Again, what's interesting is when we did a study not too long ago in telehealth, last year, mental health nationally was the most prominent diagnosis. That nationally has moved down, as you can see, to number 5, but that's not even in the top 5 in Arizona. You could see behavioral health conditions toward the bottom of at least the top 10. Again, it's interesting to see chronic respiratory issues on a telehealth listing of top diagnoses. Very, unusual compared to some of the other states around the country. again, showing that, people in Arizona are being resourceful, are reaching out to different kinds of venues to really get the care they need. And so it really reflects sort of the personality here of the healthcare system. In terms of telehealth usage, very similar to the country as a whole in terms of who is accessing care. So in addition to tracking and trending different kinds of treatment protocols and diagnostic presentations, epidemiological changes, we look at costs quite closely. With the billions of claims that we have, we're really able to parse out billed charges to the allowed or the negotiated amounts and compare different percentiles. There's not a single fair health value that we offer. When we look at cost and pricing, we array it from often the 50th to the 95th percentile, or even going down to the 5th percentile. And then we also can compare it to Medicare. And what has happened, particularly in the surprise billing conversation that's underway feverishly in the country right now, again, there's that interest in trying to find an equitable point by which providers can be reimbursed. And so what people will ask for are different points, data points along a continuum. Here we looked at a common emergency code provision, and what we did was we took 3 geozips in Arizona, and we looked at it from the 80th percentile of charges, the 50th percentile of charges, the 80th percentile of the negotiated amount between the plan and the provider, and the 50th percentile compared to Medicare. First, you should see, obviously, the CMS rate is flat because, as I mentioned earlier, there's only a single geozip, one value geographically for Arizona. But then you could see the array of different pricing points, and that has implications if you're moving to a statutory or regulatory solution in any context. Here's another very common, the emergency code visit for high severity, life-threatening. Again, you could see the variation between the geozips. You could see the variation between the percentiles. So, for example, in New Mexico, they just passed a law, a surprise billing law, that is fixing reimbursement at the 60th percentile of the allowed amounts. So again, that was their decision after looking at an array of data. And not only can we look at variation between geozips and variation between billed and allowed amounts, it's also fascinating to look at variation between venues of care. As I mentioned earlier, this transformation in the healthcare system has huge implications on the out-of-pocket costs of the consumer, as well as the cost to the healthcare system writ large. Here we're looking at a 15-minute office visit, same code, but that which presents in a retail clinic, an office, a medical office, or in an urgent care setting. And you could see this is at the state level, comparing Arizona as a whole to the nation as a whole. While Arizona and the nation, the hierarchy between the venues similar, you could see how it's very different between the different venues of care. And here is a different venue comparison, looking at hospital outpatient costs for arthroscopy and colonoscopy to an ASC costs. And so what you see in the blue is the 50th percentile of the median, the 15th percentile of charge versus the 80th percentile of charge, juxtaposing ASC and outpatient charges. And so you can see quite readily how there is a tremendous difference depending on the percentile, depending on the venue. Finally, just wanted to bring you into a little bit of the work that we've done in the opioid crisis. We've done 4 white papers that keep going deeper and deeper and deeper, sort of into that ocean of claims to really try to understand what is happening under the hood with respect to this crisis. And what our last white paper showed, we were asked to do a 50-state survey of the top 5 procedures associated with opioid abuse and dependence, and then look at the top 5 highest cost centers associated with care to that population. And what we uncovered, and don't worry, I'm not going to show you 50. I took 4, some in your neighborhood, and then just showing you a state on the East Coast, to just give you a sense of that variation. Where the colors are the same, it means that it's the same service that's being rendered, the same coded service. When it is white, it means that there is no match in any of the other states. And what you can see here is that there is tremendous variation. Some are looking at intensive outpatient, some are doing group therapy, some are doing regular psychotherapy, some are just doing office visits, some are doing medication management. So it varies dramatically. And what has not happened is The question hasn't been answered, what is working? No one seems to be looking over the fence of their neighbors or across the country to look at what is the impact of really adopting these various protocols. Likewise, when you look at costs, you can see in Arizona, testing for the presence of a drug, like New York, is the most expensive, but it obviously varies dramatically as you start going from state to state to really see what is really taxing, in terms of the financing of these various programs. So that is something that we really welcome doing. We look forward to really following cohorts through the different protocols to really understand what is happening, under the hood of these different treatments. All right, well, the scuba diving into the ocean is done. Thank you so much. I appreciate your attention.
If you could boil all this down, I guess, to the question of, you mentioned further academic study, further research in some of these topics, and I guess if we shift that a little bit from a more academic lens to a policymaker lens, what do you think the governor's staff or the health department here, the Medicaid and larger access healthcare cost containment system agency here, what should they be digging in on from a policy perspective?
Where does one begin?
Yeah.
There are so many issues that could be really looked at closely. Because we have the commercial population, to me, one of the things that would be fascinating is to do a number of comparisons with the Medicaid population, to look at how treatment protocols are different or the same. So to really try to determine, are reimbursement decisions driving some of those clinical decisions? Are outcomes different? So that lends itself to a really fascinating laboratory. One of the other things that we find really interesting is looking at consumer experience and patient engagement. As I mentioned earlier, that was part of our mission, was to create that website. We have a survey on our website that tries to elicit feedback from consumers. Are they finding this information valuable? Are they using it to really become advocates for themselves? And we're getting really important feedback. It's almost like a living laboratory on the consumer website. And I think it's important for public officials to really have that listening loop back to the patient, because that will drive a lot of the ways in which transparency regulations will be designed, language that will be used, and so forth.
Yeah. It's always interesting to see the thing that we all know, which is there's wide price variation, not just in billed, but in paid claims. But it's always interesting to see that. Do you have any observations about, this sort of urban and rural divide? It's clear in the data, both at the 80th and the 50th percentile, the urban areas are more expensive. And generally speaking, care that is more expensive is often lower quality, empirically. But nobody likes to say like the urban areas are lower quality than rural. Maybe the rural folks like to say that, but any observations about that continued divide, which we all know about, but which we rarely see so starkly?
Right. I think some of the findings are really counterintuitive. I think a number of people assume it's more expensive in urban areas. We're finding that not the case. And you probably even remember from Alaska, because there are some remote areas that are underserved, to really incentivize providers to come to those areas oftentimes leads to higher costs associated with the care rendered. Mm-hmm. And sometimes there are monopolistic practices. What we do with our data is we introduce extreme outlier methodologies that take from the high end and the low end, those really anomalous types of charges that would skew the distribution, because so many licensees and stakeholders are using our data either for statutory uses or regulatory uses, and we want to make sure there's integrity to the data. Yeah. What's really difficult is when there's not just an anomalous claim, but when there's an anomalous geozip, where you have a monopolistic practice there that is really skewing what would be typically the charges, even if you looked across the country as a whole. Toward that end, we feel like our role is to bring visibility to that anomalous geozip itself, and it can be urban and it can be rural. but it usually is one that's not super densely populated with healthcare providers. And what we'll show are histograms and other types of tools that will contextualize those prices against the backdrop, not just of the state or the region, but of the country. And that often speaks for itself. And I think because healthcare pricing is really, there's a laser-like focus on it right now, I think there's a lot of interest on the behalf of the medical societies, for example, to ensure that there's defensibility in the pricing and that some of those, extreme outliers, they almost welcome that kind of focus.
Yeah, interesting. A question over here. Sir, why don't you stand up and introduce yourself and your organization and fire away.
Thanks very much. My name is Jess Yeller. I'm with United Healthcare Community Plan. So we're the Medicaid arm of United Healthcare here in Arizona. And I'm curious about the data you displayed on there, particularly around the 60 years old and above. Is there data in there? We have a lot of winter visitors here, right? And so can you tell if a lot of the utilization in that pocket is for permanent residents, or does it also include winter visitors?
Okay, well there's a couple of answers to that. Of the 150 million covered lives that we have, approximately 75 million of those are longitudinally trackable. In other words, we have a de-identified member ID for those. The others do not have an ID. It's sort of a population health where we can look at trends in general. For those that are trackable, we would be able to see where their care is, and we can look at it by date of service. So we would know if for 6 months they're receiving care here, but then we would have that same trackable ID. We would know that they are receiving care out of the state. All of the data we show is based on place of service. We track data by where the care was rendered. And so we want to make sure that we're providing a window into that particular healthcare market, not from where necessarily the patient lives. So yes, with those that we don't have where we don't have a de-identified ID, we have an imputation methodology, and we have statistically defensible ways of assigning a patient based on what care they have received. So we would be able to even track those that do not have an identifiable ID. So the short answer to your question is yes, we would be able to know whether there's traveling between states and there's a real divide that would show that they're a snowbird or another seasonal type of resident.
It would be interesting, and I'll just volunteer Dean and the rest of your team to do some of this work if you're up for it. It'd be interesting to take some of those, particularly the 60-year-old behavioral health utilization, and track that by season, maybe quarterly, to see if there's a spike in winter months vis-a-vis summer months, which would be interesting for a host of reasons. It would mean there's a lot going on in the wintertime, right? If there's a real, to the gentleman's point, if there's a real diminishment in the other months. I don't know if you can pull the Florida data off the top of your head, but in some of these other sort of seasonal destination markets, do you see a similar trend of 60 and over utilization that is different than the Dakotas, for example?
We definitely saw it in Texas. In Florida, I don't want to speak out of turn because we haven't done a state-to-state comparison in that regard, but it was certainly the same thing was striking in Texas in terms of the really disproportionate number of those over 60 having a behavioral health condition. And also with one thing I should point out with respect to substance abuse, though, why it may not have been as high, what we're also seeing in the opioid epidemic, a lot of people crossing state lines, right? So a number of people are leaving to go to drug testing centers and other rehab centers out of their state. So again, that also suggests some medical tourism that's involved in those statistics.
It is interesting that it took a lawsuit to get one place with all of this data, that the market couldn't figure out how to do this on its own. But now that we have it, it's informed, to your point earlier, it's informed this sort of surprise billing issue and what is allowed in an out-of-network situation. So tell us how your index, how your data is sort of replacing the what used to be kind of the standard for maybe we're going to benchmark against a percentage of Medicare, but now policymakers in states and in Congress are saying, well, let's use the fair health data. What does that mean and what does it look like?
Well, a couple of reasons why they're turning to Fair Health. One is, as a national repository, unlike APCDs, we can show apples-to-apples comparisons across state lines, and there's a standardized mapping that goes on that allows visibility into those different variables. The other thing you may be aware, with APCDs, the Supreme Court in the Gobet decision coming out of Vermont ruled that APCDs are not permitted to mandate the collection of self-insured data, which is a very large piece of the healthcare system. We get that data voluntarily. So that's another reason why they come to us. With respect to Medicare, Medicare has been expressly excluded from a number of these legislative solutions that have been proposed recently for various reasons. One big reason is, as you know, given that it was and is a government fee schedule that was created for the elderly, the disabled, and stage renal disease patients, it was not necessarily intended to be servicing the general population. And because it's a federally created fee schedule, it embodies in it certain policies. You can agree or disagree with those policies, but it is driven by policies, different types of care that are trying to be encouraged by the federal government, and it's subject to a certain budgetary constraint. Yeah. It doesn't necessarily mirror the heartbeat of the market or what's going on the ground economically. So oftentimes that's a non-starter for the provider community, because when you look at, and you may have seen just in the few examples I gave, CMS tracks much, much slower than even negotiated amounts between the parties. And when it's at least the negotiated amount, putting aside the billed charge, it reflects some benefit of a bargain between two parties that have come together, as opposed to a federally imposed fee schedule that wasn't even necessarily intended for this purpose.
So is the idea that an out-of-network charge might get paid at the 50th percentile of paid claims in the given GeoZip or state market? Yes,
well, the median amount of allowed amount, that's being now discussed in some of the bills. Yeah. Originally, the Senator Cassidy, and he's part of a 6-senator bipartisan panel, they originally proposed 125% of the median allowed. That's being amended. So there are a number of different data points, many of which, though, expressly tried to move away from Medicare, because in order to bring the parties together, that then becomes somewhat toxic in the room. Yeah. And I think people really want to reach consensus on this issue. Everyone agrees consumers should be protected. Let's try to find some equitable way to reimburse the providers that the payer community can live with as well.
It might have been a reasonable thing, perhaps, if it's an N of 1, because it's maybe the only apples-to-apples data point that we have, and now we have a different data point to consider. So you live in this data and you sort of stew in it, and you've been thinking about it for 8 years now?
10.
10? What advice would you give healthcare organizations in the private sector about how to use your data?
I think that there are many creative ways to use their data. There's sort of not a one-size-fits-all. So, for example, health systems are very interested in looking at our data to see how patients are migrating out of their system. As you know, so many health systems now are assuming risk. There's value-based care, different payment models, but that only works if you know, or if you have control over the course of treatment of your patient, so they don't have visibility when they go outside those confines, so they're using it for that purpose. Payers are really interested in understanding clinical trends to make sure that their provider networks reflect the population. So with type 2 diabetes potentially escalating, they want to make sure they have enough endocrinologists or enough specialists in the substance abuse area. So there are many different questions that can be answered by the data. We sit and try to listen to what the goals are, and we can try to navigate them through that ocean to make sure that they don't hit the rocks and that they get to the other side that they want, where they want to arrive.
Yeah, good. Question over here.
Yes, thank you. My name is Suma, and I'm coming from Health Current, State Health Information Exchange here in Arizona. And my question, Robin, is what percentage of the total claims that are captured within your databases what is that percentage as against the total percentage of claims paid in the entire country? And if you could talk a little bit about if there is data that's any kind of variables that go into the information that we have seen today because of the sources from where that data is coming from. In other words, it's skewed in one direction or the other. because of the sources of the data that's coming in. The kinds of sources is really where I'm curious about. And then any kind of timeline. How often do you receive this information? Is it 30 days after the claim is paid, or 6 months? How old is the data?
Okay. Let me see if I can remember all those questions. Okay, so our data in the aggregate represents about 75% of the commercial population across the board. Some states are closer to 95%, some may be like 45%. But in order to be a qualified entity, as I mentioned earlier, CMS had to determine that we were statistically significant in every state. The data are coming in from payers, third-party administrators, national and regional insurers, as well as TPAs. In order to participate in the data contribution program, they have to adhere to a number of requirements, one being they can't basically cherry pick between programs. If they're participating, they send us everything. We make it very easy to receive data. We do all the mapping on our end to make sure that they're apples-to-apples maps in terms of our specialty index, place of service, all the different fields are aligned. And then it goes through a pretty rigorous auditing process. So for example, if there's an invalid procedure code or zip code, it gets edited out. And then of course, at the end of the day, we impose our various statistical outlier methodologies on that. And then I'm just trying to think of your last question was, how recent? So yes, our data comes in monthly, and so it would be a date of paid service from a prior month, and then that's aggregated. Our benchmark modules go out twice yearly. Each capture a 12-month current window of data, allowing for a 3-month window to do QA and production. So for example, if an anesthesia module were to go out in January, we would lock down anesthesia claims at the end of October, allowing for the next 3 months to do sort of a data check and QA check.
Great. Well, thank you for coming and making this trip here. Let's give her a round of applause. Thank you, Dal. I appreciate it.
Yes, thank you.